about the possibility of a adult onset ADHD, which is still kind of in the works, but we're changing as we go through and learn more about this problem. It has to be present in 2 or more settings, so it needs to be present in school and home. Don't be fooled. I have been many times by this, so let me explain what happens. I'll have a child coming in to see me for an evaluation. I have them in the playroom. I also have cameras in the playroom, so I can watch the kid when I leave the room and see what they're like when I'm not in the room. And they just sit there and they don't do much of anything. I bring them back for the second visit and it's like a tornado. They're like, because when a child is first in a novel setting, they're very calm because there's a lot of new stimulation to kind of filter through. But when you bring them back to that same environment the next time around, now you see the true child. So a lot of times I would advise people, if you're going to evaluate, watch them over time and in several settings to see it. So I even go to classrooms. I'll go into the schools and I'll sit in the back of the class, or I'll try and sneak in so the kids don't see me, and then I get to watch. It's always funny because the child that I'm there to evaluate doesn't look half as bad as the other 2 or 3 that I see in the classroom, right? And the teacher's always telling them, sit down, be quiet, sit down, be quiet. All right, so again, the different types that I talked about may be changing over time. I'm seeing more articles about that. There was even a talk about making a separate category for girls, or bringing back the old classification of ADD, because there were 2 types of ADD. There was ADD with and without hyperactivity. That's what predated the current nomenclature that we have. Okay. The diagnostic workup. How many of you treat ADHD? Great, yay! We need help. When I'm doing the evaluation, I try and spend at least a few hours with this child and with the family. And some of the developmental history issues that I look at are, I asked the mom, when this child was inside of you, did this child move more than the other children that you carried? And if they say yes, that to me is kind of like, okay, that's kind of a red flag, because these children are usually hyperactive in the womb. You know, they're in there carving their name on the wall or whatever, but they're busy, right? They're in there, they're moving. I also ask about how they are motorically. These are children who usually will crawl backwards or have uncoordinated crawling. So I ask about that and hear from the parents about what happens. Also, difficulty with feeding. As you know, feeding is a very complex issue. You're talking about 16 muscles that have to work in coordination in order for the child to swallow and take in substances, right? So these children have a lot of difficulty with swallowing or rooting or latching onto the breast. I also have these kids being described to me as hard to care for infants. Not colicky, but hard to care for. Because no matter what you do, it doesn't seem to be enough for them. They're like the bottomless pit of need, right? They're insatiable. You can't give them enough. They're also very tactile defensive. So these are the kids who, they don't like that label touching their skin, or they like to walk around the house with no clothes on. And my older son was like that. He just didn't want to have clothes on. They are also kids that you're more likely to see with neurological soft signs. I don't see Dr. Carlos in here anywhere, right? No. But these are the kids that, you know, usually you should have separation of left and right hemispheres about 5 or 6, right? So this is one of the things I'll do is I have the kid hold their hands out and do this, right? And what you'll see is this side is moving. They don't have that separation. Or when you have them doing the dyskinesis and they're hand flipping, you'll see this hand also moving at the same time. When you have them walk on their toes, they posture a certain way. And when they walk on their heels, they posture a certain way. They can't do straight line heel to toe without a lot of stumbling or falling off, so they're kind of clumsy and they get into a lot of accidents. These are kids who get stitches in their face a lot. So you'll see a lot of above the eyebrow, or the cheek or chin, and so I have all of those, so I can attest to that. Those are issues that I kind of look at in the developmental scheme outside of the normal standard kind of questions that you would do in a developmental workup with a family. And then I look at the clinical information. Now, what's the reason you're here today? Why did you come in here? What brings you in? And I can tell you a lot of stories. Let me give you a few that I've heard over the years. This was when I first came to Guam. I was working at the Department of Mental Health, which is now Guam Behavioral Health Wellness Center. And they would staff these cases with me. So they bring this case to me of this little boy who always embarrasses his mother in public. I said, well, what's going on? He said, well, a few weeks ago they were at McDonald's and they're standing in line and they're in back of this woman who's pretty big and she's pregnant. And she had a pager on it, started to beep, and the little boy says, look out guys, she's backing up. You know, I'd be thinking about a contract for Comedy Central. And then I had this boy several years ago, he's in class at St. Anthony, and the nun is going through the classroom asking general questions, and she says, does anybody here know what the initials at the end of my name stand for, the RSM? I think it's Religious Sisters of Mercy or something like that, right? So I know. Says, okay, what? Raise some money. His mother got a little talking to. But these kids are very quick, very spontaneous, and that's what gets them into trouble. I also look at the family dynamics because, again, you're going to usually have one parent who has a disorder as well as the child, and that leads to some very, very bad parent-child interactions. These kids get abused more often, physically, emotionally, and so you've got to be on the lookout for those kind of issues as well, and then trying to bring the parent into the fold to understand what's going on. The most common age or the most common grade that I see for first-time referrals is 3rd grade. What happens is these kids are smart enough and bright enough where they can sail through the first few years of school without a problem. But when they hit 3rd grade, they have to sit there longer, they have to focus longer, they have to pay attention longer, and then they start to hit the problem area, right? I've even had some people I've worked with who didn't get their problems until college. They're smart enough and bright enough to get through it, but when they get to that level where they really have to focus and put their attention into something, they're not able to do it and sustain it. And the other part is motivation. They'll have the motivation to do it, but that motivation goes away. So that's part of the executive dysfunction that we see in the frontal lobe with ADHD. They'll do great on Monday, but they'll really be bad at it on Thursday, and you won't know why. And so the teacher and the parent are pulling their hair out like, how come you did it so great on Monday and you can't do it on Thursday? Well, I don't know, they can't tell you, but their motivation is gone. It doesn't stay fixed. Again, looking for the occurrence in more than one place. And as I talked about, that first visit in the office may not be the do-all, the tell-all for you. You may need to bring them back a second time, and then you'll see more of a problem. And because I've been doing this now for about 29 years, what I do is I have a scale in my head. And I look at a child and I place them on my scale of 1 to 10, 10 being very severe, 1 not that severe. And that then also helps me to delineate where they fall on the treatment protocols that I develop. Is it going to just be behavior modification? Is it going to be behavior modification with family therapy, with medication? All of that depends on how they fall on the scale in severity. And I have a lot of kids that I treat who are 12s on the scale of 10. I mean, they're off the board, right? And when they come in my office manager knows incoming, and she's got things tied down, she gets stuff out of the way, because they're like a whirling dervish. They get in the office and they're like, right there all over the place. I used to have a gum machine that lasted about 3 or 4 years, but my office manager said if she stepped on another piece of sticky gum or had to get more gum off the floor, she's gonna scream. So it's in a file, it's in a closet somewhere in my office, not to be reawoken. The other thing, and you know, I don't expect that you guys would do this kind of stuff, but I use rating scales because you need something that's kind of objective to help you with this. And let me just show you briefly. I use Connor's rating scales, but these are not the only ones, but these are very good. I use a self-report Connor's rating scale for the kid to fill out. It has 99 questions. It's pretty lengthy, and if I can get them to finish this in a couple of weeks, I count myself lucky. But that gives you a view of how the child sees himself. I did have one for the parents to fill out. It's 110 questions long. Okay? And then I have one for the teacher to fill out, and it's 115 questions long. So if I'm going to evaluate, I want a 360-degree picture of this child, right? And if I just look at him in my office and I don't pay attention to what the teacher has to say and what the parent has to say, I've lost a big part of my picture. So I'm going to look at the child from the home, from the teacher, the computer test that I give them, the interview that I do with them, my observations, then I can put that together and have a high, reasonable expectation that my diagnosis is accurate. If not, I'm going to blow it. And so it becomes something that you can't just do by, flying by the seat of your pants. You really have to take your time and take a look at this. So with that in mind, let me go to the next one, which is the differential. The differential has gotten more complex over time because ADHD very, very rarely occurs all in and by itself. I think that's more the exception than the rule. Most of the kids that I treat with ADHD have something plus ADHD. So they're going to have ADHD plus anxiety or depression, or they're going to have disruptive behavior where they're oppositional and defiant to authority, or their conduct disorder like a lot of my DYA kids who are in jail, or they're going to have some other thing that's going on, like a neurological problem. There's a well-known fact that kids with ADHD have higher rates of seizure disorders. And not epileptic seizure, they can have non-epileptic seizure disorders, which means that you give them a stimulant and they become more explosive because you set off that part of the brain that controls emotion. The limbic system gets fired up and they're more explosive. So for those kids, sometimes I have to treat what I perceive empirically as a subclinical seizure disorder before I can put them on a stimulant. Because if I put them on a stimulant and they blow, I got a major issue, right? So be careful when you start looking at this. So looking at the diagnostic differential, the big hotbed right now is bipolar. We weren't talking about bipolar disorder in children until around 1995. We didn't think it even existed, like we didn't think depression existed in children until the 1970s, but it is prevalent and it is there, and there's a lot of overlap in the symptoms of ADHD and bipolar. And so it becomes very complex and hard to discriminate sometimes. So I'm always on the lookout for that because, as physicians, we always make our move based on our last mistake. And I've been burnt so many times by bipolar, I don't even want to tell you about it. It is tough. And you consider it takes 8 to 10 years to get a right diagnosis for bipolar. A person will see 4 doctors before they're given the right diagnosis. 69% of people walking around who are bipolar are called something other than bipolar, so it gets really, really tricky. And when it's lumped in with ADHD, it's a nightmare to try and figure out what to do, because if you give them stimulants again, you can set them off into a manic episode and make them more explosive. So mood disorders, about 33% of mood disorders like bipolar will have ADHD on top of that, okay? And then if a person has ADHD, there's about an 18% chance that they will have bipolar. So again, it gets very difficult and tricky to figure this out. I use in my office a mood disorder questionnaire. You can get it off the internet. It's about 13 items long. Its answers are yes or no. If there's more than 7 yeses to those questions, then it's a high index of suspicion for bipolar disorder. And it has a good validity, reuptake or revalidation scale on it. So pretty good. It's called MDQ, Mood Disorder Questionnaire. Okay? And it goes like this. Have there ever been periods of time when you weren't your normal self and you were so hyperactive, that you got yourself into trouble? Yes. Were there periods of time when you weren't yourself and you were so energized that you didn't need to sleep? These are kids, sometimes they can stay awake all night and the next day they don't need to go to sleep. They're energized and funny. They keep going and going. The other big areas are anxiety disorders. Let me just say real quickly, this one, disruptive mood dysregulation disorder, is under the heading of depressive disorders. The criteria is that the child has to have at least 3 temper tantrums per week. But this was put in place to try and get rid of the overdiagnosis. I'm sorry, I went backwards. Which way did I go? Sorry.
The left side.
Okay.
Left.
Left. Okay. So this disorder was put in place because they thought there was an overdiagnosis of bipolar. I don't like this diagnosis very well, and I'm starting to suck up to it because there's a lot of research on it now and it's starting to show some validity. But that's when you'll hear more about it. Any of you heard about this one, disruptive mood dysregulation disorder? No? Okay. Won't bore you anymore with that. The other big one is anxiety disorders. Generalized anxiety disorder is where the person has a lot of worry, and that worry causes the person then to have irritability, loss of concentration, disruptive sleep, problems with easy fatigability, muscle tension. OCD is very prevalent with ADHD. Matter of fact, you'll see a lot of Tourette's, OCD, and ADHD together. They're all in the same genetic allele. Panic disorder as well, and then social anxiety. Social anxiety is just where the child feels that when they're out in public, people are judging them and watching them, so they don't like to go out and be around public, or they start acting out. And so when they're acting out in these anxiety disorders, they can look kind of hyperactive. And then, of course, autistic spectrum disorders. When years ago we were told that you could not call a child with ASD or autistic disorders ADHD. We've thrown that out. So you can do that. And now there's a high rate of intellectual disability and ADHD together. So those two need to be looked at. Substance abuse issues. These kids a lot of times self-medicate with stimulants or inhalants or PCP, and it makes them look worse. There's a study showing that with ADHD, there is a higher rate of substance abuse. That's before medication. So you have a lot of parents say, oh, doc, I heard that if you put my kid on Ritalin, they're going to end up using cocaine. Not true, okay? And tics, Tourette's actually decreases with stimulants, not the opposite. A lot of people used to think that, but I've seen that in my office practice, that a lot of these kids do much better with tics when they're on stimulants. Okay, so next one, treatment. The first one I like is tincture of time. I always wait. I wait and I wait, because that might give you a lot more information about what the issues are besides ADHD. Third and fourth grade, again, is a common age, but I'll wait sometimes 3-4 months before I do anything. You have a large window of opportunity. If the child is 15 and they've been in DYA 3 times, your window of opportunity is very narrow. You got to work pretty quickly to change that around, or they're going to be in prison for a long time. So you're okay when they're 8 or 9 years old. You've got a window of opportunity for maybe a couple of years to try and get to the bottom and figure out what to do to help this child and the family, right? So I wouldn't rush into this. Behavior modification, definitely top of my list is the first line of treatment. I'm using point systems, token systems, calendars with stars on it. But understand that when you use a modification system, if you dangle the carrot in front of the kid too far in advance, it doesn't work. Like the parents will say, oh, if you just behave at school, we can go to Disneyland next summer. Ain't working. They need constant feedback. And so one of the parents will say something like this, well, Dr. Bellis, they can do that video game so doggone well, how come they can't do their homework? Well, let me tell you why. Because that video game gives them moment-to-moment feedback of whether they're doing something right or wrong. They get yes, no, yes, no, yes, no, yes, no. It's like the binary system of 1 and 0s, right? So it's quick. No teacher on earth can teach you that fast. In a classroom, these kids are bored to tears because they're sitting there and it's like, first you open your book to page 33. And they've lost them, right? So they need a lot of rapid feedback to let them know that they're on track. So if you're going to do a behavioral system, you need to have consequences that are pretty immediate and fast so that the child knows they're on track, okay? Almost out of time, so let me jump to medicine really quickly. The mainstay, of course, is the stimulants. Ritalin is probably the most researched medicine on the face of this earth. It's been out for, what, 40 plus 50 years now? You're not going to get any more research than what's done for Ritalin, but it's still controversial. People don't like this medication. When I go to American Academy meetings in the States, there's at least 300 people out front with placards, stop drugging the kids of America, right? And we hate that. They hate us, right? But it is still the mainstay, and it's effective 70 to 80% of the time, unless you have another problem. If you have anxiety or depression, the effectiveness of the stimulants drops by 20 to 30%. So you've got to tackle those underlying issues along with the ADHD for it to really be helpful. I've given you in the handout, you can look it over, there must be 14 formulations of Ritalin right now in the market. I gave you a handout that shows even the latest in developments, one with a liquid solution. There's some slick delivery systems. There's one where you swallow it, the Ritalin on the surface comes off, and then it opens up pores where water goes in, it pushes out the rest of the Ritalin over a 10 to 12 hour period. That device comes out in the bowel movement hole. They cannot crush it or chop it up. It'll remove the integrity of the system. I use the amphetamine salts for younger children because it seems to work better in kids under 6. If you use Ritalin sometimes and it doesn't work, think of switching to Adderall. If you use the Adderall amphetamine salts and it doesn't work, switch to Ritalin. One or the other will get you. And if neither one works, drop back and use a non-stimulant, which would be like atomoxetine, or better known as Strattera. There have been a few cases of liver issues with those medicines, the non-stimulants, so you have to monitor liver function over time. There are the non-stimulants that I use, clonidine or catapress, or guavacine. Both guavacine and clonidine have been formulated into long-acting medicines, and they're FDA approved for ADHD. So if you have a child that's not doing well on the stimulant, think about Intunav, which is guavacine, or KPEV, which is clonidine. Now, clonidine is more sedating, so I use it at night, because what happens is you give kids ADHD medicine in the daytime, their symptoms are abated, but at night when the medicine wears off, their symptoms pop back up and they can't go to sleep. What makes you think it's the medicine side effect that's making them not sleep? No, it's their ADHD has come back. I give them a little small dose of clonidine, off they go. Some I even give a small dose of Ritalin at night, they go to sleep. It's not the ADHD, it's not the medicine side effect. And then the last is some of these kids don't do well on any of the things, and I have to use the AEDs, like the anticonvulsants, like Tegretol, Depakote, Lamictal. That seems to be very helpful. So I think I'm out of time now, right? And I need to leave time for questions, so let me stop. Any questions? Yes?
I was wondering if you could speak to about the therapy component, and on Guam, what are the resources we have? Because I see a lot of it, and I do have to admit it is tempting sometimes because we only have maybe 30 minutes with the patient instead of a few hours, and sometimes parents also think that the medicine is just easier. And so I was wondering if you could speak to the therapy component.
You bet.
Where you refer.
I do a lot of my own therapy. I'm old school, so I like to give medicine plus do therapy, but I do have therapists that I use in the community. Lily Perez is one that's well-versed in ADHD. I use Amy Romero. She does a lot of cognitive behavioral therapy. Risha Uggan is another one that I've used in the community. There's not a lot of people out there. I'm the only one in private practice, and I must turn down 5 or 6 people every week. I cannot do it, right? But the therapy part, the biggest issue is getting people to understand that this is not an excuse for bad behavior. I'm offering you an explanation. Because when the day is said and done as a forensic evaluator for the court, it doesn't matter whether you're schizophrenic or not. If you understand what you did was wrong, you're guilty. So this is not an excuse, but I've had a child killed on this island with ADHD because he did something that was impulsive and he got shot, right? So you try and work with the family to get them to have an understanding and take a disability perspective about this problem, but it doesn't excuse the behavior. They still are held accountable because in the big world that we live in, we're all accountable for our behavior. Okay, but that's kind of in a nutshell, but it takes a long time to get parents to come on board, and especially if they see the kid doing well one day and then doing terrible the next day, they're like, you better behave. You know, they don't take well to that, and neither do the school environments that they're in. Anything else? Yes, Art?
You comment on the relationship between Asperger's syndrome and
Yes, there are studies showing that there are higher rates of ADHD in kids because we used to have 4 types of autism. That's been totally knocked out with DSM-5. We now only have autistic spectrum disorder. It goes from least to most severe type, right? Asperger would have been on that far least type of autism, right? But there are high rates of ADHD with kids who have the old classification of Asperger's, which is now the least severe form of ASD. So yes, there is a connect. I don't have the numbers, the statistics to tell you, but there is a lot of overlap with the two. Any other? Yes.
Is there any evidence about the effects of media, whether it be video games and stuff, that may be associated with ADHD?
I just read an article last week that says we're all ADHD because we're getting bombarded with so much information that we have to be like that to keep up with it, right? There are studies that show that some kids actually improve with using certain types of video games in terms of focusing and helping them to do better eye-hand coordination. And, you know, I don't want to give a black eye to the media or to the people that make video games. I think that, again, this has been around for 100+ years. So if it was caused by these issues, then it shouldn't have been present 100 years ago. So I couldn't blame all of this on one thing. I think this is multifactorial. I think this involves intrauterine issues as well as postnatal issues. It involves a lot of things. We know cigarette smoking, secondhand smoke, lead. There are a whole lot of issues that add to this picture. I couldn't say that it was one thing that makes it. Okay?